Welcome to the Association of Clinicians for the Underserved and the University of Michigan's Center for Managing Chronic Diseases presentation entitled Building an Asthma Care Home, Engaging Clinicians, Patients, and Caregivers in Comprehensive Asthma Management. My name is Corden Kane, and I'm the Coordinator of Program Evaluation at ACU. The ACU is excited to be partnering with the CMCD on this webinar. This training has been developed through a cooperative agreement with the U.S. Environmental Protection Agency's Indoor Air Quality Division. Our speakers today are both from ACU, Lois Wessel and Anna Gard. Lois Wessel, RN, CFNP, is the Associate Director for Programs at the Association of Clinicians for the Underserved. In that position, Ms. Wessel has developed and delivered training modules for community-based clinics in the areas of asthma education, prevention of early childhood caries, health literacy, medication management for patients with limited English proficiency, and use of medical interpreters. Additionally, she has produced low literacy diabetes materials in English and Spanish. She is the ACU EPA Grant Project Co-Director for Comprehensive Asthma Care, Effective Strategies for Health Professionals to Implement Environmental Trigger Management in Underserved Populations. She is bilingual in English and Spanish, and she's a trained medical interpreter. Anna Gard, FNP BC, is a family nurse practitioner and health disparities consultant for the ACU. She serves in the National Health IT Collaborative for the Underserved Workforce Development Committee and is also a HIMSS member. She is a team clinician for the VNA Community Health Services Children's Clinic, a nurse-managed health center, and Level 2 recognized patient-centered medical home. Her key areas of focus are the intersection of health disparities, quality improvement performance, patient-centered medical home, chronic care management, and health IT and safety net populations. Lois and Anna, you may begin.
Thank you very much, Corden, and thank you all for joining us today. Just to start, the Association of Clinicians for the Underserved was established in 1996 by participants and alumni of the National Health Service Corps. We are more than 8,000 clinicians, 900 organizations who are involved with the ACU, and we invite you to become a member of the ACU and check out other things on our website which may help you improve your care to underserved populations. The ACU focuses on clinicians and on the whole clinical team, the doctors, the nurses, the respiratory therapists, the physician's assistants, the social workers, the community health workers, the administrative folks, to provide tools to better serve the needs of underserved populations to reduce disparities. To that extent, today we're talking about asthma because of the high rates of asthma disparities among low-income populations. And to borrow a saying from the American Lung Association, when we talk about many other things, the bottom line is if you can't breathe, nothing else matters. So today we're going to talk about a fictionalized character whose name is Rosita. She's not a real person, but she's like so many of the children I see in the community health center where I work, and many of you probably see children like Rosita too. They come in with chronic exacerbations of asthma. Their asthma seems not well controlled. They're getting care from a variety of different sources. They may not understand how to use their medications. So we're going to talk today about how we can make a patient-centered medical asthma home to meet the needs of Rosita and other children like her. But before that, I want to talk a little bit about the background of asthma. The current prevalence of asthma is about 8.2%. That's about 25 million people. About 52% of these, so a little more than half, have had acute asthma attacks within the last year, and many of them were at risk for adverse outcomes, such as emergency department visits and even hospitalizations. Adults with asthma in the past month have reported missing about 15 million workdays. And for children with asthma, their parents are missing workdays if they need to be home with them. We know that the statistics are underreported. The diagnoses may range from reactive airway disease to a post-viral cough to an upper respiratory infection or simply shortness of breath. Clinicians are often hesitant to diagnose asthma if they think it's related to a virus, and the patients don't want to hear that they have asthma either. Sometimes improper coding may lead to underreporting. We'll talk today a little bit how electronic health records might improve asthma diagnoses and coding with clinical decision support and with an electronic health record. A little more about Rosita. She's a young girl, goes to the local elementary school. She lives with her mother, her sister, and her cousins in a very small apartment. It's overcrowded. Rosita doesn't have her own bed. She sleeps on the couch. Her mom doesn't smoke, but her uncle smokes, and he tries to smoke outside, but when it's cold or rainy, he smokes in the house. Before getting involved with a local community health center, Rosita's mother took her all over the place. She took her to a minute clinic. She took her to Doc in the Box. She took her to the emergency department. She made the rounds of all sorts of places where she thought that they could help Rosita. And every time Rosita was seen with an acute exacerbation for asthma in an urgent setting, but she never got primary care and education to prevent her asthma from getting worse. Sometimes her mom got prescriptions for medications she couldn't fill because of the cost. Sometimes the medications and the patient instructions were giving to her in a language she didn't understand because Rosita's mother, like so many of the mothers that I see, don't speak English as a first language, and even her Spanish reading skills were not that good, so materials in Spanish were a little hard for her to understand. She was always told to follow up with a primary care provider, but she didn't have a primary care provider. It took 6 months for Rosita to get enrolled in a local program, and that was because the school nurse pointed her and her mom in the right direction. Her and her family never understood that she had a chronic disease called asthma. Sometimes she was diagnosed with reactive airway disease, but in the different places she was going, nobody knew how often she'd been seen in other places because there was no continuity of medical documentation between the different clinics. Rosita and her family faced many disparities with asthma. As I said, they're doubling up with relatives in a very old apartment where the landlord does minimal upkeep and there's problem with leaks and mold and cockroaches. Her mother struggles to pay for food, for clothing, to pay for the rent, and to buy the medication. Her mother is one of 14% of people in the United States who have a health literacy level which prevents her from performing basic tasks that require reading and filling out forms. So many times forms were given to her for patient assistant programs for some of the medication or to enroll in a local health center, but her reading level was not well enough that she could fill out this form. This meant that often she was getting materials, but she couldn't use the materials to best help Rosita understand when and how to take her medication. So her asthma was poorly managed. In addition, the cost of medication was prohibitive to her, so when she walked away with a prescription for a couple of different medications, she had to just pick one to fill. She often didn't know where to go. The hospital was open 24 hours a day. The urgent care was open 24 hours a day, but she didn't understand the role of a community health center or a local community-based clinic. We talked about her literacy level and the fact that she speaks English poorly, and she has what we call limited English proficiency. But we didn't speak about the culture of asthma. In her country, people believe asthma goes away. You outgrow it. You take the medicine and you get better, just like you do with strep throat. So she didn't understand that asthma is a chronic disease. She was also a little fearful of the culture of the medical world. She was afraid of walking in and being reprimanded for having a daughter who was so sick. She wasn't sure exactly where to go. She was afraid that she'd be charged a lot of money. She was afraid they'd ask about her immigration status. So there were many things that were in the way of her getting quality primary care to keep Rosita's asthma out of control. So some of the barriers that she faced that we've mentioned, the poor housing where there's a lot of asthma triggers, the cost of medication, and her health literacy led to a situation where Rosita was sick a lot. During her acute exacerbations of asthma, she couldn't go to school for a couple of days. Her mother didn't want to send her to school coughing and wheezing. So those were days that her mother couldn't go to her own job and earn money to help with the family. There's a statistic from the Environmental Protection Agency that says people spend 90% of their time indoors. And the asthma triggers we're going to talk about later in this presentation today are the indoor asthma triggers that Rosita was exposed to. In a study done by the National Center for Healthy Housing, they said that a working family had to earn $14.66 an hour to pay for safe housing. Well, Rosita didn't have anybody earning $14.66. That's more than minimum wage, and she only had one adult who was helping raise money for the family. It made it very hard for them to rent a facility or an apartment that had a sufficient environment that would not exacerbate her asthma. Children often miss a great deal of school due to asthma. It's reported that 10.5 million school days are missed for children with asthma. And for many children, school is the most consistent thing in their life. Their teachers, their guidance counselor, the school nurse, we're there every day with them, seeing them, and understand what's going on in the home and the problems that may be relating to their inability to get their homework done. So it's often this spiral that goes down where they miss school, they fall behind, they get frustrated, they have trouble concentrating, they're nervous about a test, they act out And children may be mislabeled with learning difficulties or ADD or behavior problems just because they've missed school due to something as preventable as an acute exacerbation of asthma. In addition, as I mentioned, Rosita was taken to the emergency department many times. And we know that in the emergency department, they make sure that you're getting enough oxygen, they check your oxygen level, they give you oxygen, they may give you a shot of steroids to make you feel better. But their job in the emergency room is to get you breathing well in that moment and get you out. The emergency room is not a place for ongoing prevention and prevention education. So this lack of access to a primary care provider, poverty in the housing that they lived in, and a delay in seeking care all led Rosita to the emergency department to get the immediate problem solved, but she didn't get any long-term education. Now, we are delighted to know that many health plans and managed care organizations are looking at putting money into preventive programs front up, such as the Neighborhood Health Plan of Massachusetts. They've won awards for their asthma disease management program, where they looked at the trends in asthma-related emergency department visits and hospitalizations, and then created self-management programs to improve the quality of care in the clinic with many interventions, including home visits by respiratory therapists, nurses, asthma educators, education on trigger and medications, and we'll talk about some of those triggers today, and environmental home assessments. And they found that they saved an incredible amount of money by putting all that energy in front up and keeping these kids healthier and keeping them out of the emergency department. So we're excited by the fact that through Medicaid expansion that's increased to 133% of the federal poverty guidelines, there will be more people like Rosita who will be able to get into primary care and hopefully get some of that prevention education done so that they don't end up missing school and they don't end up in the emergency department. And we look at this in terms of a medical home, a place that can evolve for children with asthma through partnerships with the funder, with the clinical team, with the community health worker. So we're going to talk a little bit about the role of the medical home and how we can improve care for children with asthma. So I'm going to turn this speaking over to my colleague, Anna Gard, who will now talk about providing care through a patient-centered medical home. Anna?
Yes. Thank you, Lois. So asthma in the patient-centered medical home, I think Lois did a very good job about talking about how our children and their families really struggle for adequate care management of their chronic illness. And without having a personal care healthcare provider and a team that helps them navigate their way through the health system, as well as understand their disease and teach them skills for self-management, we find that many of our children and families fall through the cracks, and they, come up against many of these barriers that they just can't navigate alone. So it would really benefit Rosita and her family to have a medical home with access to care, which would be a personal primary care provider, to medication management and support, to an effective patient tracking system, so that a health system that will contact them when they've missed appointments or when they're due for a flu shot, and also for good avenues of communication that may be in their language, and certainly that pays special attention to issues of health literacy. In fact, there was a study from the New York-based Children's Health Fund Childhood Asthma Initiative that demonstrated when children received best practice asthma care in a medical home model, there was significantly improved asthma control, reduced hospitalization and ED visits, and calculated that the annual savings to the healthcare system exceeds $4,000 per child with asthma, and this is based on conservative estimates. This savings is nearly 11 times the cost of integrating this best practice model into the primary care setting. This is a research article that was in the Journal of Healthcare of the Poor and Underserved and will be available on our resource list. But what the patient-centered medical home model does is it provides us an opportunity, particularly with chronic disease management, in this case asthma, to really improve the quality of performance measures, and to narrow the disparity gap that occurs in health outcomes for underserved populations. The benefit of being a patient-centered medical home model, besides the patient benefit, is that health centers may be able to take advantage of private and public incentive payments that reward patient-centered medical homes. So in an asthma care home, the patient is in the center, and we talk about patient-centered care. That is care that is organized around the patient and their family. We often think of asthma as clinicians as a disease, and yet a patient experiences asthma as an illness, which has very many personal and social impacts. Asthma as the disease is the same, pathophysiologically, the management, but as an illness, it is different, and it's affected by cultural and social and psychological factors with each individual. And as Sir William Osler once said, it is more important to know what kind of patient has the disease than what kind of disease the patient has. So in looking at patient-centered care, it really gives attention to asthma as an illness. How does this disease impact this patient? As you can see in the slide here with the 6 bubbles, that the 6 standards of patient-centered medical home model really address issues that are often barriers with our vulnerable populations. So they address issues of access, of medication management, patient tracking, communication, care coordination, and health literacy. So when we talk about integrating the asthma guidelines, we really need to focus on evidence-based guidelines that help our clinicians with clinical decision support. And as we look at asthma over time, we have understood more detailed ways of managing asthma, and we have certainly much more effective treatments for asthma, but we have not necessarily seen a corresponding decrease in asthma morbidity and mortality. So we need to look at why this is. Are patients and families not recognizing symptoms of asthma? Are clinicians not making the diagnosis? Are they not coding it appropriately? Are they reluctant to give a chronic disease diagnosis? Are clinicians not following the evidence-based guidelines? And are patients not adhering to recommended programs? In the best case scenario, the primary care team has been educated on the best practices with the most updated clinical practice guidelines. And the team, seeing the chronic nature of this disease, can address the appropriate medication guidelines along with trigger management. But we're not necessarily seeing this, and this is one of the reasons why we have really looked at developing asthma care within the patient-centered medical home model, because it may help us integrate these guidelines in a more efficient, effective way. So if we look at asthma care, we look at, again, these 6 bubbles around asthma care, and we're going to talk in specific detail about each one. The first is, as part of the asthma guidelines, is that every patient who is diagnosed with asthma must have an asthma assessment, their severity level documented for every new diagnosis. And in fact, when research studies look at clinical practices, this is not necessarily being done. There was an interesting research study that looked at the implementation of an electronic health record, which prompted clinicians to categorize or classify asthma severity, and that when using the electronic health record, many more patients had a severity classification documented in the chart rather than when they were using a paper-based chart. You can see on this slide here that in order to assist patients with asthma severity classification, we really need to develop some provider-friendly tools that are easy to use and that they really support the workflow of an office visit. So looking at the guidelines and taking those guidelines and creating a form that can be embedded in the electronic health record that helps clinicians determine the severity based on their symptom assessment. So that would be their impairment, which would include the frequency and intensity of symptoms, or their current or recent functional limitations. Also looking at risk. And risk really includes the likelihood of exacerbations, decline in lung function, or potential adverse effects from medication. Asthma Action Plan. According to the most updated 2007 guidelines, all patients with asthma should have a written asthma action plan. And in creating an asthma action plan in coordination with the patient and family, this really provides the patient and family a tool to refer to when their asthma is acting up. And oftentimes, the most universal asthma action plan that is used is that of a stoplight, because in many cultures, the stoplight is universal. And it is simple. It's a simple analogy, and it's easy to use. Green meaning when you're symptom-free, these are the medications you take. Yellow when you're starting to experience early symptoms of asthma, and as a provider to go over what that means, whether that's nighttime cough, needing to use your rescue inhaler more than twice a week. This is the plan that you need to do, and then what the red zone means is when you are in danger and you're having a severe asthma flare. The benefit of an asthma action plan is that it helps engage the family in self-management and improves confidence in the management for the child and for the family members to feel like they have some level of control over their child's asthma. This also can be used as a coordination vehicle across multiple caregivers and linking between the community and the clinic. That being that when in the clinic, the patient and the family and the clinician sit down and go over an asthma action plan. That plan can be embedded into the electronic health record if you have an EHR. Otherwise, it can be a part of the paper chart. A duplicate form can be provided to the family so they can keep it home, on their bulletin board, on their refrigerator to refer to. Another copy can be sent to the school nurse, as well as perhaps the daycare provider or grandma who takes care of the children in an after school, or even summer camp. So this is a way of linking the community and a way of health information exchange to all members of the healthcare team who are supporting this patient with their asthma care. Assessing and monitoring asthma control. Control is the degree that the asthma symptoms are minimized by the therapeutic interventions that have been prescribed and that the goals of therapy are met, meaning symptom-free. Impairment, again, is frequency and intensity of symptoms, and risk is the likelihood of exacerbation. We, again, need some very simple, easy-to-use tools for both the patient as well as the healthcare provider to assess asthma control. Asthma control should be assessed at every single visit outside of an asthma exacerbation. So, for example, if you have a child who's coming in for their well child check, their asthma control should be assessed. If they are coming in for a skin rash or for an unrelated activity, their asthma control should be assessed. In order to do that in a efficient way that doesn't completely disrupt the workflow of the office visit, we can use tools like the asthma control test, which is a simple 5-question tool that's self-administered by the patient or family member, and it's been clinically validated by specialist assessment and spirometry, and it's been recognized by the NIH. And again, we'll include this in our resource list, but you can easily Google the asthma control test and find a copy of it for both children from the ages of 4 and 11, and then from the age of 12 and up. And it is available in both English and Spanish. Using an objective test like this is quite helpful because asthma symptoms are variable from patient to patient. And families need to recognize symptoms and adjust medications at home according to the clinician's assessment of control and his or her asthma action plan. And so this just reiterates what are considered symptoms of asthma, because in many families, they don't necessarily recognize that a nighttime cough or a child coughing when jumping rope may be early symptoms of asthma worsening. Inhaled corticosteroids, and I think for many of us clinicians, when the latest guidelines came out, this was hammered home as a very significant message. But still today, we see many patients who have not had their severity of asthma documented, and because of that, because they are not documented as a persistent asthmatic, they are not prescribed inhaled corticosteroids, which are considered the mainstay of asthma medication management for asthma control. So one of the problems Rosita faced in her care prior to coming to the clinic was a lack of understanding of controller medication, such as the inhaled steroids. The inhaled steroids are very expensive, and of the two that were prescribed, her mother only purchased one of them. This is a great challenge with uninsured patients, underinsured patients, and also patients with low health literacy, because one, they certainly have difficulty accessing the medication due to the cost. Two, they may have limited ability to distinguish the difference between the multiple inhalers, and they may have difficulty in understanding the dosages and the timing, problems understanding the side effects, and therefore real fear related to potential side effects, and a lack of understanding of labels and delivery devices. I had a middle school age child who told me that she had multiple inhalers. She didn't use any that she had, but she borrowed her friend's because it was pink, and she happens to like the color pink. So this is where medication management and incorporating adequate and health literate, culturally competent communication is really vital to make sure that our patients are managed appropriately with their medication and to improve safety and efficacy of our medications. So some of the tips that we have are making sure that we simplify our care instructions for medications and trying to dose all of our inhalers at the same time of day to avoid any confusion. If you are unable to access spacers for your patients because they're not covered by insurance or they are uninsured, we have had some recommendations to use 1 liter water bottles and to use the capped opening for the mouth and to cut a hole in the bottom piece to slide the inhaler in and use that as a makeshift inhaler. It's not ideal, but it is certainly sometimes much more effective than not using a spacer. Making sure as a clinician that when you write for a prescription that you write for a refill, but make sure you're monitoring for control. Allowing a patient to have a refill will keep them from being caught short without medication, but not writing for more than one refill, because we know if a patient is filling their reliever medication more than twice a year, that we are not adequately controlling their asthma with our medications. E-prescribing should really aid with this for those of you who have an electronic health record. And our communication and patient education is really central in patients' comprehension of their medications and how to use it and the point and purpose of the medication. There are some really wonderful videos available, and we will, again, have that included in our resource list that show patients appropriate use of inhaler techniques, which is really an important part of medication management, and that is in proper demonstration and teach back of how to use your inhaler. Just a slide to show you the cost of many of the more common inhaled corticosteroids. They are certainly not cheap, and unfortunately, many of the $4 prescription programs through places like Target and Walmart do not include inhaled corticosteroids on their list. So although we know inhaled corticosteroids are the most effective long-term control medication for persistent asthma, it's still a barrier to access them for our patients. One recommendation is to identify and develop a model of standing orders for your patients on the use of inhaled corticosteroids for anyone who has persistent asthma. So again, that goes back to making sure that all clinicians document the severity of the patient's asthma. So all persistent asthmatics should have a standing order for a prescription of an inhaled corticosteroid. Try and identify and reduce the barriers to inhaled corticosteroid use among your patients and families. Knowing your patient population, what are their barriers? Is it because there's not any pharmacies close by? Is it because of cost? Do you have anyone in your staff who can help support the patient assistance programs to access those medications for your patients? And this is where advocacy comes in, is to partner with payers to address costs of effective asthma control and relative costs of providing inhaled corticosteroids with respect to patient outcomes. Because we do know that when we control our patients' asthma with inhaled corticosteroids, that lessens their risk of being hospitalized or having emergency department visits, which certainly costs much more than a monthly prescription of inhaled corticosteroids. As I mentioned, sometimes fear of side effects may be a barrier, and so it's important in your teaching to your patients to review medications and potential side effects and highlight the fact that inhaled steroids are the mainstay to control all asthma, and that it reduces the need for more frequent use of quick-release medications, and that it has much fewer side effects than steroid tablets or syrup, and certainly has no impact on growth. Sometimes there's a confusion when you say the word steroid, and these families think of it in the negative concept, like illegal steroids taken by athletes for for performance enhancement. And so that really requires a little bit of discussion about the difference and reassurance. And once you provide that reassurance, hopefully they can put that concern to sleep and will be more apt to use their controller medication on a more regular basis. Pharmacists can really be a tremendous partner in the care that we provide to our patients. And getting to know your local pharmacist that services your community is really important, because they are really considered a part of the extended healthcare team. If they begin to know this patient and family, then they will communicate with you in terms of whether or not this patient has been trying to refill their medications more frequently or hasn't refilled their medication as due. So really keeping pharmacists as a part of the healthcare team will help support the entire asthma care home for your patients. Planned follow-up visits. An essential and important goal in Rosita's care is ongoing treatment and education. And the goal is to keep Rosita in school and to keep her asthma in good control. This is the type of care that a community health center can provide, but is limited in an urgent care center or in a minute clinic. For Rosita and her family, this may mean coming in for planned care visits, participating in an asthma educational group, or getting annual flu shots. Planned visits are a part of the national guidelines for comprehensive asthma care. Planned visits give you an opportunity to assess asthma control during a non-exacerbation. Many health centers have creative ways of scheduling their planned visits. Some health centers schedule a week every October and every spring for planned asthma visits, where they contact all of their asthma patients and have them come in for that week. During that visit, they assess control, they make sure all their patients get their flu shots, and they may be running some group visits at that time to review asthma medication management or environmental triggers. This is sometimes a very effective way to run group visits and also make sure that you get your patients in for their flu shots. It's a good opportunity to check adherence to medication, inhaler technique. Patients also like to learn from each other, so having group visits during these planned visits may be an effective way to do your patient education. As I talked about group asthma visits, we can often bill for these visits, and they're often led by a certified asthma educator or by a respiratory therapist or the community health worker who's had special training, or an asthma nurse specialist. In a 2003 randomized controlled trial, when an asthma nurse specialist provided group education sessions to adults in the clinic, the intervention cost $186 per patient and saved $6,650 per patient in direct and indirect expenditures. So that's $36 saved for every dollar spent. This was located in the American Journal of Respiratory Critical Care in an article in 2003. Seattle King County Healthy Homes Project and Neighborhood Health Plan of Massachusetts gets reimbursement for their community health workers who run group asthma visits. And again, as I said, patients and families often like to know that they are not alone, and they learn from one another during these group asthma visits. Asthma home visits. Home visits by a nurse or a community health worker can bring together the clinical picture with the reality faced by the family. Oftentimes, when a community health worker goes into the home, the community health worker is from that community. They may be familiar with that family and with the neighborhood, and there's a sense of trust and understanding that happens when the family invites this person into the home. Often they will share information with the community health worker that they may not share during an office visit in the health center. And this may be issues of, they may share that they have an issue with mice or rats or cockroaches, or share that they have had a significant mold problem and they've been struggling with the landlord to address the mold issue. So often during these home visits, community health workers will use home assessment tools. The EPA has a tool that is available. It's the EPA Home Checklist, and that's downloadable for free off of their website. As I mentioned, Seattle King County Healthy Homes has gotten a Healthy Homes grant, and they have done home environmental assessments with the community health workers going into the homes. These community health workers also provide individualized action plans and make additional visits over 12-month periods to provide education and social support. This really has shown significant improvement in asthma management, as well as reduction in emergency room visits and hospitalizations. One of the things also that can be done during these home visits is it does give the home visitor an opportunity to assess other social determinants of health, things like hunger or nutritional deficits, food storage issues, also family stress. And we know research shows that psychological stress can really have a tremendous impact on the exacerbation of asthma. But in doing all of this asthma education, it's very important, and I think Lois began talking about some of the barriers of Rosita and her family, highlighting issues of health literacy and cultural competency, is providing health education in a way that it will reach the patient and their families. How often during our busy clinic day do we print off a handout and just hand it to the family, when more appropriately is to understand how people best learn, and sometimes multiple modalities can be effective. So there are books available in Spanish. There are some wonderful videos. As I mentioned, the Northwestern University Feinberg School of Medicine has patient education videos on environmental trigger control, appropriate inhaler use. And Sesame Street has a wonderful program called A is for Asthma, and they have a toolkit for parents. They have a video for children and parents, and you can also your families can also sign up for an A is for Asthma newsletter, which provides patient-friendly information in a medium that is well received by families and particularly children, and that is all of our Sesame Street characters that we're so that we've known for and grown to love over time. So now I'm going to hand this back over to Lois, and she's going to talk about the specifics of the environmental triggers and give you some realistic and practical recommendations for remediation.
Thank you, Anna. And if you recall, Anna said earlier on that the national guidelines say that one of the things that should be done is to reduce exposure to asthma triggers. And we know in the clinical setting, often what happens is medication gets prescribed, a little bit of education gets done, but we often don't get to that level of talking about what should be done in the home to reduce the person who has asthma's exposure to indoor air triggers. So we're going to talk about the fact that we know that medication is important and essential in asthma control, but so is the reduction of exposure to indoor asthma triggers. And this area of patient education and clinical care is sometimes overlooked, or we just don't have time to do it all. But environmental trigger screening should be part of the asthma care visit, and if we're lucky, we're in a clinical situation, we do have home visitors going into the home to talk about these things. One of the things I want to talk about with reduction of indoor asthma triggers is that the goal setting needs to be done by the patient. One of the things that they may want to reduce exposure to may not be the same thing. For example, as a clinician, I always say, you got to get rid of the smoker in the home, you got to get rid of the smoker. And maybe for them, the goal is to make a sleeping environment safer for the child. So part of this is partnering with families to make sure that the goal setting is appropriate to meet the family's needs. And all the education should be done in plain language. You need to remove the medical jargon, and we'll talk about some of that in a few minutes. The asthma control that we're going to talk about for these indoor asthma triggers are the ones that have been pointed out and outlined by the Institute of Medicine's Clearing the Air. This book examines how indoor air pollutants contribute to asthma, the causation, the prevalence, the severity. And so the indoor asthma triggers we're going to talk about next are based on their most current findings and that have scientific basis for being an allergen or an irritant for asthma. So the first one I'd like to talk about here is dust mites. And what I often say to patients is that dust mites are everywhere. Even if you can't see them, we know that they're everywhere. And dust mites, like the rest of us, like places that are warm and soft and fluffy. So the more warm and soft and fluffy places you have in the house, the more dust mites you're going to have. Because sometimes it's hard for people to understand what is a dust mite when you can't even see it. We certainly support allergen-proof covers for bedding and pillows. We know that those may be hard to purchase for some families. So in terms of building partnerships outside the clinic and with the community, one solution that I've seen in Washington, D.C. is a clinic that was adjacent to a new Target, and they were able to work out a relationship with the Target where the clinicians could write on a script from the clinic that they wanted an allergen-proof cover for the bed, and the patients could go to that Target and get it at a cheaper price. One of the things that's also talked about with reduction of dust mites is cleaning the clothes and all the bedding in water that's over 130 degrees Fahrenheit. So in terms of partnering with families and understanding where they're at and being culturally appropriate, if we say, you really got to make sure the water you wash your clothes in is 130 degrees or higher, that's probably setting up a false expectation for a low-income family who may be walking down 2 or 3 flights of steps with all of the laundry. They would go to the closest laundromat, and they're probably not going to ask the laundromat owner what the degrees of the water is, and then if it's only 127 degrees, they'll take their laundry and walk another 6 blocks. People are going to wash their laundry where it's convenient. The other thing is that as clinicians, we often tell our families to turn down the hot water heater so the child who is learning how to go to the bathroom and wash his or her hands afterwards doesn't scald themselves. So we have to make sure we're not contradicting ourselves in one visit talking about not having the water so hot and another visit having the water very hot. And one of the things that we found through our research in preparing this presentation is that Frequent washing is the best thing, and it doesn't necessarily matter the degrees, but washing bedding frequently in hot water is key. Talking to families about having washable windows, shades, carpeting is also very important. But again, we must look at the cultural setting in which the family lives in. And I recently had a family who had moved here from Guatemala where they had dirt floors, and they were so excited to be in an apartment with a rug, with wall-to-wall carpeting, that they took pictures of themselves and sent that back to their community in Guatemala to show that they had made it in the United States because they had wall-to-wall carpet. So it was not going to be a priority for that family to pull up their carpet and have wood floors because that was a status symbol for them. So asking about some of these things certainly is important. I don't want to say that the child can't have any fluffy materials on the bed, but if the family understands that the dust mites live where there's fluffy things, then having 6 stuffed animals or 12 stuffed animals on the bed brings in more dust mites than having 2 or 3. So one of the easy solutions is to rotate them. One week you have Snoopy, and the next week you have Hello Kitty, and the next week you have your little gatito, your little stuffed cat that you like, and it may, you may have to rotate the animals. But one of the things that's also key is that many children from low-income families don't have a bed that they sleep on that's a mattress. They may sleep on the couch, and it may be the same couch that the dad came home on and sat and smoked a cigarette, and the dog jumped up on, and the brother sat there and ate cookies and got cookie crumbs. And so there was some residue of the smoking in the couch, and there were crumbs which bring dust mites and roaches. And so it's important to say, tell me about where the child sleeps. The dog wants to get on the couch if he knows the crumbs are there because those crumbs are delicious. So we want to talk about creating a safe sleep environment, but understand that if we say the bed needs to be a safe place and the child doesn't have a bed, that we're setting up a barrier. In terms of actual pests, and we're talking about cockroaches, mice, and rats, what is an allergen for people is the hair, the skin flakes, the dried urine and dried saliva that fall off. And for cockroaches, it's the body parts as well as their excrement. I think it's really important to enforce with families that they're not dirty. They didn't do anything wrong. I've seen mice and cockroaches in my house that, again, these are living creatures that like the same thing that the dust mites like and the same thing that we all like, warmth and food. And so we really need to think about the big picture of getting rid of their food supply and making an environment that's not hospitable to them. And things that can be done are washing out bottles and cans before putting them in the recycling bins, throwing out old stacks of newspapers which can harbor moisture, thinking about cleaning products, which we'll talk about in a few minutes with respect to mold, that may also trigger asthma, washing and drying dishes and putting them away, wiping down wet areas, not storing wet sponges under the sink, keeping lids on trash bins and keeping the lid on the trash bin, and storing pet food in airtight containers. But it's also important to understand, like everything else, there may be a cultural context here. And I had a family with a child who had a lot of asthma, and the home had many pests. And the way the dynamics worked in that family is the dad got up very early in the morning, 4 or 5 o'clock in the morning, and went to work doing construction. And the mom got up and prepared food for the day, got the kids off to school, and she left the food out for the dad when she went out to do her job cleaning an office building at 4 o'clock in the afternoon. And when I said she needed to put the food away because that food was attracting pests, she said her husband wouldn't like that. In her culture, since she couldn't be there to serve him the food, she had to leave the food all out ready for him. And we brought him into the clinic and said, in addition to feeding you, your wife is feeding the cockroaches and the other pests. And so we had to work with the family system to say if she put the food away and he had to take it out of the refrigerator and reheat, it wasn't a lack of love for him. In fact, it showed more love for him that she didn't want him to be exposed to the excrement from these little creatures. So that's something that's important to think about. With respect to eradication of pests, one thing that we know a lot about from working under this EPA-funded grant is integrated pest management. And integrated pest management, or IPM, is basically a safer and less costly option for pest management, where you want to use the smallest amount of the least toxic material to get rid of pests in the smallest area possible. And so we go back to thinking about the crumbs that are in the house. One thing that's important to think about is if the family only ate in one area of the house, there may be more of a possibility that the crumbs would stay in that area in the house and the pets as well. pests as well. So if you're using hazardous materials to get rid of the pests, you wouldn't have to do this all over the entire house. So things to think about are that people may be using poisons that are actually harmful to children. And we look back to the issue we talked about of literacy and health literacy. They may not be able to read the instructions on the materials they're using. I know in my community they sell something in the Hispanic corner stores in the bodegas that's called Chinese chalk, and it looks like a piece of chalk, and it's wrapped up in something that's written in Chinese, and people kind of color in where they think they've seen roaches and rats, and I was thinking that maybe this was something that has limited toxicity, such as boric acid, when in fact I brought it to somebody and said, what is this? And she read it to me, somebody who was Chinese, and in fact it was very toxic. So people may be buying things that we don't know what they are, they don't know what they are, and using them incorrectly. So it's not inappropriate to say, please bring into the clinic visit the materials you are using at home to get rid of these things, so that I can make sure that you're using something that's safe and that's not going to hurt the family. Other things that can be done that are very effective, that are part of the fundamental principles of integrated pest management, are using the sticky traps, using where a mice or mouse might get stuck on that and then could be disposed of. The little roach hotels where the cockroaches come in, have some poison, and go back to the nest usually to die, and they get eaten by their other cockroaches in the cockroach community, who then also ingest some of the poison and die, and eliminating the food and water sources for these animals, these pests, and then, as I said, using low toxicity materials where appropriate. And one of the ones that's found to be low toxicity and works very well, if not used in extreme amounts, is boric acid, which needs to be placed with a very fine film. If you have too big of a little line of boric acid, they turn around, the pests turn around and walk in the other direction, where if it's a very light film, they walk through it and get some of that on their body. The next one I would like to talk about is mold. And I alluded to that before, that in communities where it's very warm and rainy, and people are indoors and it's old housing, there may be a lot of mold, and there may be mold in places that we don't even see, such as behind the wallpaper, or in a basement, or in a closet. Some creative ways to get rid of mold include circulating the air, using exhaust fans, drying clothes outside, or drying clothes in properly vented dryers. We've seen some low-income families who intentionally have their dryer vent drying into the living space to keep the house warm, but that means they're also putting moisture and lint into the air, which probably will exacerbate the asthma. Repairing leaks where you see them, decreasing humidity, but probably the most important thing that we've learned is that there's no product that you can buy to get rid of mold that's better than any other. In fact, the mold experts at the EPA have told us that the best product is elbow grease, and that means getting a stiff brush and scrubbing mold where it's been seen. Other ways to reduce mold are keeping lights on in closets and basements, which will retard the growth of mold. If you do have moldy areas in the bathroom, the dollar stores often sell shower curtains for $1, so throwing out an old shower curtain and replacing it, having washable curtains and bath mats in the bathroom, and washing them every week when you do the laundry to reduce the mold, those can also be key. I'd like to talk a little bit now about pet dander. And for many people, their pet is another member of the family, a much beloved member of the family. So this is often very hard. The child likes to sleep with the pet. I feel bad that I said that the child can't have too many stuffed animals on the bed. I didn't mention that one of the places where mold can grow is inside the rubber duckies, and having open bath toys instead of the little closed bath toys where water and then mold can start growing because the water's in there can occur. And so I feel bad because I've talked about things that the children shouldn't have, and now their much beloved pet may be something that's causing them a problem. Dander can also be brought home. It's very sticky, so especially cat dander. So asking where the family members spend time. It may even be a sibling who's spending time at a house with a pet, and that sibling doesn't have asthma but bringing home the dander. A family member does spend time at household with pets. They may need to change their clothes and wash their clothes to avoid bringing the dander into the home. When taking an environmental history, it's very important to ask about pets other than cats and dogs, pets that they may have in their classroom at school, and that's anything with fluff and hair: gerbils, hamsters, rabbits, birds, guinea pigs. Many people will tell you that they have a non-allergenic cat or dog, and really there's no such thing. The only household pets that are non-allergenic are fish or usually reptiles, but cats and dogs or anything that's furry can be an allergen because of the skin flakes, the urine, and the saliva. So it's important to vacuum as much as possible, and again, make sure there's a safe sleeping environment for the child. And in some cases, keeping the pet outside as much as possible. And lastly, we've seen cases where giving away the much-loved family pet has really improved asthma of a member of the family. So that always needs to be in the back of your mind as something that the family may need to do. Of all the triggers that we talked about, mold and dust mites and cockroaches, many of us have had those in our home and seen those in our home, and that's not necessarily a behavioral thing. But tobacco smoke is something that is a behavior of somebody who lives in the home. And we know there are many reasons why there shouldn't be smoking in the home. Some 53,000 people die annually from secondhand smoke, and children who are exposed to secondhand smoke have more frequent and more severe asthma attacks. We recently did some training with the Hawaii Primary Care Association, and I was startled to find that more than half of the high school students in Hawaii smoked. There may be other issues and health concerns related to smoking, including ear infections, pneumonia, SIDS, and certainly cancer. According to the Allergy and Asthma Network, Mothers of Asthmatics, most children with asthma who are treated in the emergency department live with a family member who smokes. So we really need to take this issue of smoking very seriously. Understanding how smoking plays out in a child with asthma is something that often we understand, but it's often hard to talk about how to get rid of the smoker in the home. We used to say, well, if you smoked outside, that was okay. And certainly smoking outside is better than smoking inside, but you still are bringing in smoke, and that's what they're calling now third-hand smoke. First-hand smoke is if you smoke. Second-hand smoke is if you're around a smoker. The third-hand smoke is the smoke that somebody else may be bringing into the house just by virtue of the fact that they've smoked or they've been in the presence of other smokers. The Association of Clinicians for the Underserved is in the process of developing a special section of our website dedicated to smoking cessation tools for clinicians. So we encourage you to look there to find some resources for patients. But it should be brought up at every visit. And for those of you who are working in clinics with an electronic health record and are looking at meaningful use of that electronic health record, understand that meaningful use requires clinicians to document the smoking cessation the smoking status of patients, and that we also must begin to look at cessation. We know that smokers below the poverty level are less likely to succeed, and tobacco use is strongly associated with low socioeconomic status. And these are the folks who may not have access to some of the great medications or alternative therapies such as hypnosis and acupuncture that have been proven to help with smoking cessation. So it's important to be familiar with programs in the community, medical assistance programs that may help get some of these drugs. I recently had a homeless patient who hugged me when I walked into the room because we had, through a patient assistance program, gotten him on a smoking cessation medication, and he had stopped smoking. Another thing that's important to remember is that one of the ways that low-income people do stop smoking is as cigarette prices go up. And so we definitely need to support legislation to increase cigarette taxes so that if people can't afford them, they won't buy them. So finding out about smoke-free legislation in your community and certainly calling the 1-800-QUIT lines are very important. We've also seen that pediatric providers are often a little hesitant to approach the issue of smoking because they're not providing care to the adults. And I would just like to remind any of our listeners who are pediatric providers that it does need to be brought up and discussed, and the resources available for the adults who smoke need to be known. And so the American Lung Association, American Legacy Foundation, other organizations have information of local smoking cessation groups on their websites. The last trigger I want to talk about is what we simply call other triggers, and they may be different for every community. As I mentioned earlier, we've done some training in Hawaii, and one of the things that we found out is VOG, which is volcanic fog, or the ashes that come from the volcanoes, is a trigger. It's also a place where it's summer all year round, and because of the tourism industry, there are fireworks all year round, and that's a trigger for people who live in those communities. So finding out if there's any perfumes or a makeup such as nail polish or those little plug-in supposed room fresheners that you plug in that are actually putting an artificial scent into the air, incense, votive candles, hobbies such as painting, painting little models or doing painting on canvas. All of those things may have scents that are a trigger. So asking what are the other triggers in the home, the HVAC system, the heating, all of these things may be a problem. So this is where it's important to know what are the other cultural issues that may be at play that keep a child in exposure to an asthma trigger as opposed to away from that. And for a Vietnamese family that I worked with who had incense and votive candles around a special religious ceremony, we encouraged them to keep the window open and to keep the ventilation going while the child participated in that, and they found that that was helpful. Landlords need to know about installing carbon monoxide detectors and having the heating systems checked, and there may be housing advocates who are helping with this as well. So understanding as a clinician who are the groups that are working on safe housing is key. Lastly, I just wanted to talk to kind of bring this all into perspective that we know that there are many indoor asthma triggers in the home, but the families may find it hard to complain. So the providers often can write a letter, and frankly, we're less threatening than a lawyer saying, little Jimmy is living in this apartment and his asthma is really bad because of the cockroaches and mold. And I would encourage you to help Jimmy's family reduce cockroaches and mold in the apartment. So that the landlord is hearing it not from a health point of view and not feeling that it's an antagonistic relationship from a lawyer. Also, with one of the beauties of an electronic health record is you may be able to pull up kids by zip codes or address, and you may find there are numerous families in one large apartment building, and many of the children have the same triggers. And that's where safe housing becomes an advocacy role for the clinicians and for the medical system so that people are living in safe housing. And there are many communities that have legal and medical partnerships. Local asthma coalitions often do great educational work and have fairs where they may be giving away spacers or having flu shots available for people or have access to some of the medications. So understanding who's in the local asthma coalition is key. We talked about health promoters or community health workers who should be part of the healthcare team, as well as we touched on school-based health clinics and the importance that the school nurse and the school-based health clinic has a copy of the asthma action plan. And as clinicians shift that plan a little bit or change things as the child becomes more stable with their asthma, maybe they don't need the same medication, we need to continually remember to inform the school-based health clinic. Also, for many of the families that we work with, they may be the aunts one night a week, the dads one night a week, the mom one night a week, and the grandmother another day of the week. So making sure everybody who is a caregiver for the child is all up to speed. We talked about using the pharmacists as well as making the local retailers make some of these things more available for patients. There are many communities that have programs that where they're really looking at working in the community together. Anna touched on the Seattle Cook County programs, as well as some of the other programs, Open Airways for Schools, WIN for Asthma, Breathe Easy Homes, Healthy Homes Projects. These are all community-based programs which help with indoor trigger reduction. And to finish up, I would just like to read something that I think brings all this together. And this was something where there was a community in Washington, D.C., where the family and the community worked together to make safe housing for the people in that community. And that was a low-income community where the children were very sick from asthma, and the parents in that community were concerned that the children didn't have. They were concerned that they couldn't bring the issues of the housing to the authorities because the parents were undocumented. So with two Latino mothers in an apartment called the Norwood Apartment in Washington, D.C., and they frankly were afraid to talk about the maintenance problems. The property management company had spread rumors about possible immigration raids if the tenants complained. So one mom was afraid to say anything about how her 3-year-old boy had allergies and asthma. There were roaches in the home. They saw rodents all over the place. The situation was very bleak. And it took 6 years, but the people in that community organized to improve their living conditions. They educated themselves about their rights as tenants. They organized a tenant association and reached out to many of the local groups that I mentioned, the Asthma Coalition, the Safe Housing, the Medical Legal Partnerships. Many of the people in this building were of Mayan ancestry, and they used Mayan art and culture to create awareness about the living conditions. So those two mothers who initially were afraid to speak out are now board members of that community, and they speak regularly at their local city council hearings about housing issues. This group, called the Norwood Tenant Association, recently received $9.7 million in funding from the D.C. Department of Housing and Community Development to purchase the building and make an affordable housing cooperative. So they were able to see that they faced many difficulties, but they realized that by working together as an organized community, they met their goal of providing a safe and healthy home for the children. So I wanted to thank you for being part of this ACU webinar, and we encourage you to look at our asthma resources, our smoking cessation resources, and other resources on our website today. Thank you very much.